So the topic today is sleep medicine for the ENT surgeon, and I would very much like to welcome my consultant colleague, Michael Farquhar, to give the talk. Mike is a bit of a guru of sleep medicine. I'll just do a very brief intro, but essentially he trained in Edinburgh and then has trained in sleep medicine in Glasgow, Sydney, Great Ormond Street, and was appointed as a consultant at Evelina in 2012. And he works in a combination of diagnostic sleep medicine and also runs specialist tertiary quaternary sleep clinics for people with complex sleep disorders, children predominantly, well, completely. A couple of other things that are interesting, he's been at the forefront of really pushing and publicising the importance of sleep and managed to push this being part of the national curriculum to be taught at schools as part of social education for children, and has also been really at the forefront of pushing the importance of sleep for healthcare professionals, particularly those doing shift work, including junior doctors. And the final important aspect of Mike's personality is his really key role in raising awareness of the challenges faced by young people who identify as LGBT and particularly their access to healthcare. So, as I'm sure you're all aware, sleep disordered breathing is a huge part of ENT surgery, both in adults and in children, and slightly different in adults and kids. And an audit we did in our department about 2-3 years ago suggested that the referrals with snoring and sleep disordered breathing in children was by far the highest number of referrals we received, and about 40% of all referrals we received. So just to give you an idea what a big issue it is. And without further ado, I'd like to hand over to Mike, who's going to speak now about sleep medicine with particular reference to the ENT surgeon.
The talk of this is sleep medicine for the ENT surgeon. It is predominantly, as Vicky kind of alluded to, they're going to be mainly about sleep diagnostics and sleep studies, and how we can use those to try and help you decide who needs treatment, how to stratify that, and use the resources you have as best as possible. To begin with, though, I'm going to give you a very brief kind of elementary idea of the physiology of sleep, which hopefully you'll be at least familiar with. I tend to find ENT surgeons tend to know more about this than many other doctors do, because I think you all have a bit more of an interest in the physiology of sleep because of sleep disordered breathing. But understanding the basics of sleep often helps us to piece together when sleep is presenting as a problem, and that's very much the case with sleep disordered breathing. So I spend quite a lot of my time looking at diagrams like these. These are hypnograms. So this is a diagrammatic representation of the stages of normal sleep through the course of a night. So we have different types of sleep. So we can all be awake, which we are hopefully just now. We can be in light sleep or deep sleep, or we can be in what we call dream sleep, rapid eye movement sleep. And each of these different stages of sleep has both different characteristics. So when we are looking at it with a sleep study, we can look at different physiological characteristics related to these stages of sleep, but they also have different functions. Sleep is something, one of the reasons I love sleep is we're still kind of unpicking lots of the intricacies of exactly what sleep is for, what it does and how it all works. But we do understand quite a lot about what sleep is for, and different stages of sleep tend to support different functions of sleep. You need all of the bits of sleep working together to get all of the benefits. And as much as possible, that means people's sleep should translate to a picture that looks something like this. Is that all right? Sorry, somebody else said. Deep sleep, which we tend to get towards the beginning of the night, is our physical restorative sleep. It recharges our batteries, gives us energy for the next days when we repair any damage, cellular damage that's happened through the normal wear and tear of the day. Kids literally grow during deep sleep. So if you don't get deep sleep, it can be a cause of failure to thrive in children. Light sleep and dream sleep have much more to do with the kind of cognitive load of sleep. So processing things that you've learned in the day. So if you don't get a good night's sleep tonight, you will not process, integrate, and remember anything that I managed to teach you in the next 45 minutes or so as well. But light sleep and dream sleep are also important for regulation of memory, for regulation of emotion. And all of these things together then help to give us the benefits of sleep. We cycle through sleep in a fairly predictable fashion through the night. So about every 90 minutes or so, we will complete a cycle of sleep. And within each cycle of sleep, we tend to start in wake, We drift down into light sleep first, then into deep sleep. We spend a reasonable amount of time in deep sleep, particularly at the beginning of the night. Then we transition back through light sleep and dream sleep towards the end of each sleep cycle. It's actually quite normal to wake up briefly at the end of a sleep cycle. And for those of you who may be parents, waking up in the night and children's ability to settle back into sleep is something they learn as they get older. The waking up is normal, and we all wake up actually and settle back multiple times through the night. As the night goes on, the proportions of sleep change. So we tend to get most of that deep sleep towards the beginning of the night, and towards the end of the night, we tend to see much more in the way of light sleep and dream sleep. The hypnogram then opens up an absolutely key concept when you are thinking about sleep from the point of view of the children that you may be seeing and presenting to you. To get good quality sleep, we need to be cycling through those different stages of sleep in a relatively smooth way. If anything affects the quality of sleep, then it prevents us moving through those stages of sleep as smoothly as we should do. And it can actually stop us getting the right proportion of sleep as we go through the night. So the two hypnograms here depict two children who have both had a night's sleep. The child on the top has had a relatively good quality night's sleep, where they've cycled through those sleep stages pretty much as they should do. The child on the bottom has had what we would call a very fragmented night's sleep. So from the outside looking in, this child will look probably as if they've been asleep for 8 hours, just as the same as the child on the top has. But when we look at the quality of the sleep that this child is getting, it is much choppier, many more transitions between sleep stages. And actually this child is spending virtually no time in deep sleep over the course of the 8 hours. So although from the outside looking in, both of these children will look as if they've had equivalent sleep, the poorer quality sleep that the bottom hypnogram represents is then what is going to result in many more problems in terms of consequences for poor sleep. And that concept of sleep fragmentation is really important. Anything at all that fragments sleep quality will then result in secondary problems as a result. In paediatrics, we can look, and actually lots of the things which will cause sleep fragmentation are the common bread and butter difficulties of childhood paediatric problems. So things like poorly controlled asthma, nighttime cough, eczema that makes somebody itch, constipation with tummy pain or discomfort, hay fever symptoms, reflux. All of these things will affect the quality of sleep that a child potentially gets and will result in this very fragmented pattern of sleep. So although the cause of the fragmented sleep is different, it all comes back down to that final result of the fragmented sleep, which then has a consequence. When we are then thinking what you spend most of your time thinking about when we're thinking about sleep, which is obstructive sleep apnea, if we go back historically to when obstructive sleep apnea was first described, what people were often worried about was the desaturations as driving the problems. What we are increasingly looking at is that it isn't the desaturation, the change in the oxygen saturation level that causes problems related to obstructive sleep apnea. It's that sleep fragmentation, which is a subtler way of looking at sleep quality than a desaturation profile. I'm not going to spend a huge amount of time talking about why we should be thinking about obstructive sleep apnea as a problem that we should be looking at, but hopefully you are all familiar with the idea that increasingly there is a fairly significant body of evidence that tells us that sleep disordered breathing in children is something that has both immediate consequences, but can then also have significant medium and long-term consequences on their health. And things, for example, like the long-term effect on cardiovascular health from childhood sleep disorder breathing makes this something that we should be looking at as a modifiable factor to try and improve the long-term trajectory of children's health as much as possible. But the slide here just shows some of the ways that disrupted sleep caused by anything, but in this case, obstructive sleep apnea can have for a child. So they can make them more temperamental, can affect their behavior, can affect physical growth, so can cause failure to thrive, can cause issues at school, so things like behavior, concentration issues. It can disrupt other hormonal axes, so it's potentially a contributing factor to problems like obesity. And then we know that there is a relationship between obstructive sleep apnea and cardiovascular health, as I've said. You will probably be familiar with the idea that in children, where sleep is fragmented and children are not getting good quality sleep, they can present with a constellation of symptoms that looks very similar to what would go on to be diagnosed as ADHD, attention deficit hyperactivity disorder. And for some of those children who look like they have ADHD, the core problem is sometimes something that is affecting their sleep, that is then giving those presenting symptoms as a consequence, rather than being a primary diagnosis such as ADHD. You will be familiar with the spread of obstructive sleep apnea in the demographics of children. So this is predominantly something that affects younger children, tends to be more boys than girls, and tends to, as we get towards the end of the pediatric age range, tends to be less of a problem. Again, I'm not going to belabor too much the anatomy and physiology of obstructive sleep apnea, because I suspect that is something you're very familiar with. But this is all to do with the anatomical and physiological structure and function of the airway, particularly in childhood. So things that you'll be very familiar with. So the relative overgrowth of adenoids and tonsils during that kind of primary school age range increases the obstructive elements in the upper airway. The key bit from sleep medicine, however, that people are often less aware of, again, I think ENT surgeons are perhaps much more aware of this than the majority, is that as we go through those stages of sleep, as the physiology of sleep changes, there are some specific effects that then have a significant impact on the upper airway. And the most important of these relates to REM sleep. REM sleep, rapid eye movement sleep, is when we do most of what we usually talk about when we say that we've been dreaming. You can actually dream in any sleep stage, but the dreams that come during REM sleep are the narrative story type dreams that most people are talking about when they dream. Dreaming represents the brain processing all of the things that you've done in the daytime, and the human brain likes to tell stories. So all of that reshuffling, organization, processing of things that you've done in the daytime, the brain is looking at all of that and it tries to piece it together into a story, which is where we think the narrative quality that our dreams tend to have in this stage of sleep come from. Sometimes that dream narrative is very obvious and you'll have very boring, mundane dreams about what you've dreamt about, what you've done in the day, then come into your nighttime dreams. And sometimes they can be completely wild flights of fantasy. But fundamentally, it's just the brain trying to make sense of whatever it is it's processing. Dream sleep, when we look at the EEG representation of sleep, it looks very similar to wake. And on one level, as your brain is processing all of this information and creating this narrative, your brain thinks that it is happening just like it would be as if you were awake. So if you were dreaming that you were climbing a mountain or fighting pirates or running a marathon, on one level, your brain thinks that is actually happening, and it would send all the messages to your muscles to make you carry out the actions that you are dreaming about. From an evolutionary perspective, that is a bad idea. If you are Zog the caveman, dreaming sound asleep at night in your cave, and you dream that you're fighting a woolly mammoth or whatever, and then you are told, your brain is telling your body to get up and run and carry out those actions, then it makes you vulnerable. And to prevent us being vulnerable in that way, our bodies evolved a safety mechanism to stop us acting out our dreams as we sleep. And that safety mechanism is very simple. We are paralyzed as we dream each night. And the way the brain and body does that is by cutting the tone to our voluntary muscles as we dream to stop the muscles acting on those signals from the brain that would be otherwise telling us to act out our dreams. So every night as you dream, you are paralyzed. And most of us are not usually aware of that. Most people at some point in their life will have the horrible experience of sleep paralysis where you wake up and you feel like you can't move. But for most of us, we are not aware of that routine paralysis. From an airway point of view, though, the voluntary muscles that support the upper airway are also affected to a degree by that paralysis. So it means that as we go through dream sleep each night, the protection of the upper airway drops a little bit, and that the ability to maintain the upper airway is more vulnerable during dream sleep. So we can see that sleep physiology as we then start to look at what happens when children present with sleep disorder breathing. There are other groups of children. So within paediatrics, we spend a disproportionate amount of our time looking after children who have specific additional problems. So whilst the bread and butter from an ENT perspective is often typically developing children with straightforward adenotonsillar hypertrophy, which is what the middle picture there is meant to represent, we also, particularly in a hospital like Evelina, London, see a wide selection of children with quite complex presenting features, many of which will then independently increase the risk of sleep disorder breathing. So conditions like Duchenne muscular dystrophy, cleft lip and palate, Down syndrome, achondroplasia, all of these conditions have different effects in terms of often to do with the airway or muscle strength or tone, which will then affect these children's risk of sleep disorder breathing. So there are specific populations within paediatrics that are more vulnerable in terms of sleep disorder breathing. The top right picture represents the fact that historically obstructive sleep apnea in children has been a different presentation of the disease to what it would be in adults. And in adults, the kind of stereotypical picture of obstructive sleep apnea is often the middle-aged man, overweight with rolls of fat around his neck, which wasn't for a long time something that we saw lots and lots of in paediatrics. As obesity becomes more of an issue across the entire age range, we are seeing more of these obesity-related presentations as well. So the top right is just alluding to that. So obstructive sleep apnea, sleep disorder breathing is something that we see a lot of and that we spend a fair bit of time thinking about, both within our sleep department and also ENT department at Evelina, London. And the question then becomes, how do we look at this in more detail? How do we assess it and work out what's going on? You'll be most familiar, I suspect, with oximetry, which is the simplest measure of being able to look at what's going on in terms of breathing and sleep. So this is really just looking at heart rate and saturation. So the red line across the top here is the saturation trace, the blue line at the bottom is the heart rate. And I suspect you would be fairly happy with the idea that if you had done oximetry and got a trace like this back, that this is telling you something about the way this child is breathing. And I usually ask questions as I teach at this point, but what this is really showing is that REM-related vulnerability of breathing in sleep. So what we see here are clear clusters of desaturation which are occurring. So if I was reporting this, I would say these are clear clusters of desaturation occurring in periods of probable REM. So whilst I can't absolutely say that this is REM without looking at sleep in more detail, this pattern of clusters of desaturation is what we see in association with that increased vulnerability with the normal REM paralysis. So oximetry can give us information about breathing and sleep, but we'll come back in a little while to why it's a problem. The other thing that you're probably familiar with is what we would call a sleep study. And generally when we talk about that, we are talking about more detailed assessments of breathing and sleep in particular. And this is a cardiorespiratory sleep study that adds in extra ways of looking at information over and above the heart rate and the saturation trace. So on this slide, what you can see is at the top left there is an overview of the entire night. So that's the oxygen saturation and the heart rate that you would get from oximetry. But then in the rest of the trace, what you can see here is this line is looking at nasal flow. So this is flow of air out of the nose, which is a good measure of flow through the system. The next two lines are looking at thoracic and abdominal muscle effort. So this is letting us look at the effort of breathing. And what you can see here is a nice synchronized pattern, whereas the thorax and abdomen are moving, they are moving in synchrony together, up and down as this child breathes. Then we've got saturation trace here, heart rate trace here, and then we would be looking at carbon dioxide on the trace here. There's not actually a reading on that one there, but we would be looking at that normally. And this gives us more information when we are thinking about what's going on at night. The best way to explain this is probably to give you a clinical example. So this is Abby, who is a 4-year-old girl who had been referred by her GP to an ENT clinic. And the referral basically says that Abby's typically developing, she's always snored, and her parents say she thinks she skips her breath quite a lot. Now, they presented to a centre where they don't necessarily have access to more detailed sleep studies routinely. So what was done in this case was that this child had an oximetry. And I usually ask people to comment on the figures here, so I will just do it for you. What this shows is the numbers that were generated by that study. So mean oxygen saturation was 98%. This study was done over 2 nights, so we got 22 hours of data, so it's quite a nice length of time to be looking at this. So mean oxygen saturation, 98%, completely normal. We tend to look at the 3% oxygen desaturation rate per hour. So the oxygen desaturation index is a measure of the number of times that the saturation drops by, in this case, 3% from the baseline and then comes back up again. So a drop from 100 to 97% counts as a 3% dip. So it's not the absolute value of the saturation that matters here, it's the relative change. And we expect that to be relatively flat. We report a 3% oxygen desaturation index of 4 per hour or less as being pretty normal. So this child has got 2 dips per hour, so it's pretty normal. And then we look at things like how much time they spend below 92%, so hardly any, and the saturation nadir is 90%. And what I normally ask to an audience at this point is, would you be happy with that? What do you think about it? And usually what I get back are people saying that these numbers look very reassuring and very normal, which they are. However, this is one of the problems with oximetry. So oximetry is not a very sensitive test of sleep disorder breathing. And actually, I think if you're used to looking at oximetry, by far the most useful bit of information is not the numbers. The most useful information is the visual trace. So this is the visual trace from that same study. And although the overall numbers are normal, what you can see, hopefully looking at this, is that there are periods in this trace where the saturation variability increases. Let me see if I can pull that up with a fancy doohickey. So these bits here, for example, where in clusters again, you can just see that the saturation trace becomes more variable compared to the interim bits where the saturation trace is relatively flat. And that increase of variability in the saturation baseline in clusters like this is another subtle indicator of that vulnerability in REM. And together with a clinical history from a family saying this child is snoring and pausing and gasping, this would still, to me, be suspicious of sleep disorder breathing, even though the numbers are normal. But this is often the only sleep study, in inverted commas, that people have access to think about to begin with. What then happened with this child was that the surgeon did have a high index of suspicion, and this child came to have a sleep study. Now, this is not her sleep study, first of all, but this is that kind of more detailed sleep study, again, that I showed you on the previous slide. And again, what you can see here is the increase in the information that we're now gathering. We're getting a much more complex picture of what's happening during sleep. This slide, again, this is usually a question I would ask the audience. This slide shows a very subtle abnormality, which again fits with vulnerabilities to sleep. If you look at the thoracic and abdominal traces, which are towards the bottom of the screen here, you can just see that where on the previous example, these were completely lined up, they are just not quite so synchronous. And this is what we start to describe as respiratory phase shift. So part of the reason of this talk is to try and explain, when sleep physicians like me talk in coded language, what that coded language means. Respiratory phase shift just means that the thoracic and abdominal musculature has become a little bit discrepant. And that's usually what we see when somebody is trying to generate increased pressure to overcome a degree of upper airway resistance. So this is one of the early signs on a sleep study that there is something going on in terms of sleep disorder breathing. Sorry, let me just get rid of that again. This study slide, though, shows this child sleep study. So on this one, we start to get the benefit of that more detailed information. So when you look at the thoracic and abdominal traces on this slide, what you can see is where before there was a subtle discrepancy, this child now has what we would describe as paradoxical breathing. So the thorax is going one way and the abdomen is going another way. This is this child trying to generate pressure to overcome obstruction in the upper airway. When we look at flow directly, which is this trace here, what we see is that there are periods where there is normal flow, but then there are periods where there is no flow whatsoever, despite the fact that we can clearly see there is continued respiratory effort. So this tells us that this child is trying to generate pressure to overcome an obstruction, to generate flow, and is not managing it. So this is what we see when we are looking at obstructive sleep apnea. So we've got an apnea here of 45 seconds, continued respiratory effort. That's associated with a desaturation here on the oxygen desaturation trace, and we score that as an obstructive apnea. So this is what we are looking at when we are trying to give you that more detailed information about whether there is sleep disorder breathing here, obstructive sleep apnea. On this study, so remember this child had what looked like a completely normal oximetry by the numbers. When she came in for her detailed sleep study, her sleep study was actually, and even from our point of view, this was disproportionately surprising. We don't normally see it being quite this discrepant. But on her overnight detailed sleep study, her mean oxygen saturation is still normal, so 96%. The 3% oxygen saturation index is a little bit up, but not terribly so. But when we look at the number of events that she's having, she was having 13 obstructive events per hour. Which I'll come on to in the next slide, is how we then stratify what's going on when we're talking about obstructive sleep apnea. We are also looking at the carbon dioxide, the bottom bit there, and that was nice and normal. So it wasn't having a big impact on her gas exchange, but we could see the impact in terms of the numbers of episodes happening. In adults, where I suspect most of you will have first learned about sleep apnea, the scoring that we use is based on the number of those episodes per hour. So we talk about the apnea-hypopnea index. So apnea, complete cessation of airflow, hypopnea, partial cessation of airflow. We count up the number of those episodes per hour, and that generates an index in terms of severity. And in adults, the scoring scale that is on the right of this table is used, where you're allowed to have up to about 5 of these episodes per hour, and it's called normal. 5 to 15 of those stratifies as mild, 15 to 30 is moderate, and more than 30 is severe. Now, even before I put the pediatric one up, every single time an adult is having one of these episodes, if you're an adult right at the low end of moderate or the high end of mild, say you're having 15 events per hour, that means 15 times every hour your sleep is being disrupted in terms of quality by a respiratory event. And I struggle to see why that isn't a problem, but I'm not going to get into the wherewithal of the adult scoring criteria. I think it still has a significant impact in terms of adults as it does in children. But in children, we take a more conservative approach to this. And that's partly reflecting the fact that children are growing and developing, and sleep is crucial to that. So we're trying to make sure that their sleep is optimized even more than adults. But the thresholds for where we consider this to be a problem are much lower in children. So we talk about mild obstructive sleep apnea as being about 1 to 5 events per hour, moderate 5 to 10, and anything over 10 events per hour we class as severe obstructive sleep apnea hypopnea in children, which would still be slap bang in the middle of the mild category in adults. So that difference in perspective of how we approach obstructive sleep apnea in children is really important. And again, and the way to think about that is that it's about the critical importance of sleep for normal childhood development. So we assume that adults are pretty much matured and developed. Children are still growing and developing, and sleep is crucial to that. So we set the thresholds lower. The other thing that's important just to very briefly mention here is that the other benefit of that more detailed cardiorespiratory study is that occasionally you will see children where there is a history of some form of sleep disorder breathing, but actually you don't think that it's explained by obstruction, and there isn't a kind of an overall impression that this is an obstructive problem. And obviously the other thing that the more detailed sleep study does is let us characterize the events in a way that oximetry can't. This is the oximetry, heart rate, and carbon dioxide trace from another sleep study. And you can see on this, that similar sort of pattern in the saturation trace, where there are clusters of desaturation. And if you just had oximetry, you wouldn't really be able to say more than that. But with a detailed cardiorespiratory sleep study for this child, what this one revealed is that the events in this case were not obstructive, they were central. And if you look down at the thoracic and abdominal traces here, what you can see is there are a few breaths, and then there is a complete lack of respiratory effort, which is then associated with a drop in flow. So this is the opposite problem. So in an obstructive event, there is still continued respiratory effort. In a central event, there is a lack of effort as the principal problem, and that's what then causes the lack of flow, and that's what causes the apnea, which in this case is then a central apnea. And obviously the workup, assessment, and management of central apnea is very different to that for obstructive. The last thing about sleep studies is it is worth saying is that, so oximetry, you kind of think of as entry level, cardiorespiratory study is the next level up. The level above that, this is me road testing our new sleep lab rooms last year, is polysomnography. And what polysomnography adds is a much, much more detailed level of sleep study that lets us directly assess the stage of sleep. So by adding on EEG leads and bits and pieces of other wires and kits and caboodle, we can identify those sleep stages that I spoke about. Now that is rarely of significant relevance to you. Where it is relevant and where you need to understand about it is that when we are scoring events in sleep, we have to be able to demonstrate an impact from the event to be able to score it. And classically on a cardiorespiratory study, we say there's an apnea and then we see a desaturation. And it's the combination of the pause in flow and the desaturation that lets us score the respiratory event. However, if you remember back to the beginning, what I said was what's actually important is not the saturation, the desaturation. That is a proxy marker of what's going on. What is important is whether the sleep is being fragmented. And that is something we can only assess with polysomnography. So this is sleep study from a child with a history suggestive of sleep disorder breathing, whose cardiorespiratory study didn't actually identify huge numbers of desaturations, but the clinician was still concerned that there was significant sleep disorder breathing. And when we did the more detailed study, so you can see again the obstructive picture with the ongoing effort but no airflow. But what you can see here, these are the EEG traces. So this is the EEG characteristics of dream sleep. So this person, this is me, was in dream sleep. There is then a respiratory event. There is no change in the saturation 99%. But what we can see, because we've now got the PSG hooked up, is that there's a change in the sleep stage from REM to light sleep, which is the brain basically going, you need to get out of REM sleep to get rid of the REM paralysis to be able to open the airway up. And that causes what we describe as an arousal in sleep, which is then the measure of sleep fragmentation. So if this was happening multiple times through the night for this person, even if they didn't desaturate, they would still have fragmented sleep that would still be secondary to obstructive sleep apnea. So what the PSG adds is if you have a high clinical suspicion of significant sleep disorder breathing, but there isn't any evidence of that on oximetry or a cardiorespiratory study, the PSG lets you really make sure that you've got that right. You can also, this is rather embarrassing for me, this was me in the lab. I didn't snore very much, but I snored enough at one point that I snored loudly enough to arouse myself from the level of sleep I was in, which is the kind of thing that earns me an elbow in the ribs if I'm doing it at home. I didn't do it very much, thankfully, so I was able to say I don't snore very much, but even snoring can contribute to that sort of arousing. Snoring, I think, probably arouses the people around the snorer more than the snorer, but it can do that. The other reason to be aware of this is that some countries, and not ours, have published guidelines. The Australian guidelines were published a few years ago, and they rather unhelpfully say that they consider polysomnography, that ultimate high-level sleep study, the gold standard for looking at obstructive sleep apnea. In this country, we very much disagree with that, and actually we've just had a letter published in Archives this month rebutting that and saying that for the vast majority of children, cardiorespiratory studies give you enough information. The important bit about that is obviously is that PSG is a much more limited resource. So if you have an Australian guideline that says every child with possible obstructive sleep apnea must have PSG, then suddenly it puts you in a very difficult position in terms of assessing and diagnosing it. So we very much rail against that. Okay. I'm going to apologize because I thought when I started this that I had more time to talk, so I'm going to go through the next little bit quite quickly, and then there's be time for questions at the end. Hopefully you're all still there. I hope you are. So what we kind of try and think about is an approach to sleep disorder breathing that makes rational sense of everything that I've just spoken about, but allows you to have a utilitarian approach to using resources appropriately to decide who do we investigate, who do we treat, how do we approach that to put it all together. And this is going to be a very summarized version of the model that we have at Evelina London, which I think works quite well. My ENT colleagues can correct me. So the first question is, do they have sleep disorder breathing in the first place? Is that causing a problem? Do they have additional risk factors? Should we treat it? How should we treat it? What do we do if it doesn't get better? So do they have sleep disorder breathing? So historically, you guys do this in clinic. You take a history, you do an examination. If everything fits, then you can often put things together then and there. If you have queries or questions, then you may want more investigations, and we can talk a little bit about that in a second. But actually, I think the thing that has transformed this is the advent of the iPhone. And I think quite a lot of your diagnoses of significant obstructive sleep apnea are probably now being made with that combination of history, examination, and good visual video information that lets you say, yep, convinced, definitely has obstructive sleep apnea, don't need any more information. And we think, Vicky and Dan can correct me, we think probably about at least 50% of children who are diagnosed with significant obstructive sleep apnea in the Evelina have no sleep study whatsoever, and the assessment can be made based on that. If there is doubt, do they have obstructive sleep apnea? Well, then that's where the more detailed cardiorespiratory sleep study is helpful. If you're sitting there going, oh, I'm not sure, this might be central, then again, a more detailed cardiorespiratory sleep study is going to help you to answer that question. But a lot of the diagnosis can be made without any recourse to sleep study whatsoever. And sleep study should be used to help inform your assessment rather than being the basis of it. The next question is then, is this sleep disorder breathing causing a problem? And the way that we encourage to think about that is to think about the secondary consequences of sleep fragmentation. And often that's where thinking about what's happening for this child in the daytime is really key. If this child is sailing through school, no problems, no behavioral issues, is thriving, normal growth, nothing else, then there's not as much of a pressure to think about doing something. If this child is failing to thrive, if they've got attention problems, if somebody's trying to diagnose ADHD in the background, then it may be worth just thinking, is the thing that's causing the problem here the sleep disorder breathing? In which case, is it then worth treating? So thinking about should we treat needs that more holistic thinking about all of the consequences of sleep fragmentation, rather than just focusing necessarily on what's happening in sleep itself. It's the secondary consequences that help inform our decision as to when anything should be done. When you're thinking about that, do they have additional risk factors? So the kind of the background to this slide again is taking in all of the additional medical problems that we see coming through our hospital that may impact on that. As I say, obesity is one that is increasingly relevant there, but we know that there are also significant differences between children from different ethnic backgrounds in terms of vulnerability to sleep disorder breathing. And all of these things together then help think about informing the decision. Should we treat it? So again, as I kind of already said, that comes back to what is the consequences, how much is this causing a problem? But then this is where if you do have the detailed information from a sleep study, you can then start to use that to stratify whether something should be done. We know that the natural history of sleep disorder breathing for many children is that if we watch and wait for a period of time, then a significant number are probably going to get better for whatever reason. So there is certainly for the milder group, if you've got a few worries, but you've done a sleep study and you know that they're in the relatively mild group, then actually that gives you a bit more space to say, actually, let's watch and wait and come back, rather than saying this child definitely needs surgery. We tend to think that once you've got to the moderate or severe ends on a sleep study, that it probably is more veering towards intervening rather than watch and wait. But again, that needs that clinical balance of everything that's going on. And again, the third bit about that is that if you know that this is a child from a group that is already vulnerable, then it may tilt your balance towards when to treat. So we're more likely to treat sleep disorder breathing, for example, in children with Down syndrome, where we know that that can be a significant contributing factor to the other difficulties that they face. Whereas a typically developing child, we might be more likely to watch and wait. How should we treat it? So again, this is where I tend to let my colleagues do the bulk of this, where you guys are the experts rather than me. But what we normally say is that there is often room, but again, particularly at the milder end, particularly for kids who may have allergic rhinitis or the suggestion of an inflammatory upper airway in particular, that things like Montelukast or the nasal steroid sprays can be helpful just to try and reduce the impact of the milder end. But for a proportion of these kids, they will go on to have a ENT procedure of some description. And again, I think I'm certainly very proud of the colleagues I work with here. I think we offer a phenomenal surgical service to the kids that come through Evelina London. And I think the techniques that we use to approach obstructive sleep apnea in our hospital compared to others means that we are often able to do surgical interventions for children where in other hospitals they wouldn't be considered appropriate for surgery. So I think the surgical options are absolutely key. If surgical options don't work or aren't appropriate, then that's where you rope in our respiratory colleagues and start thinking about the funky options for ventilation for the kids who are more severely affected. And again, you then often then get back involved with these children again if they end up getting to the point where they're so severely affected they need tracheostomy. But there's a variety of different options, and usually most children, particularly typically developing children, can be managed with the combination of the first two of those. I said I would come back to discuss oximetry again. So historically, oximetry has been looked at as a kind of it's the only diagnostic tool we've got, therefore we should be using it if we're thinking about doing a sleep study. We are trying very much to encourage people away from that. We know that the sensitivity for oximetry as a diagnostic tool for obstructive sleep apnea is pretty low. And what that means is that if you've got a history of obstructive sleep apnea and the oximetry is normal, the history is probably more likely to be telling you what's going on than the oximetry. So as I showed with the example earlier, you can have fairly good going obstructive sleep apnea and have relatively normal looking oximetry. Where we try and use oximetry within Evelina London is not to make the diagnosis of sleep disorder breathing, it's to help assist the surgical team to stratify the severity when we're thinking about where that child needs to have their operation done and what needs to be available in terms of high dependency beds or monitoring, which is often the way that we phrase it. And if you've got a child that's got good going obstructive sleep apnea, you're persuaded by the iPhone history, but you just want to check that things are okay. If they've got this kind of oximetry profile, then you would be more confident that this child is not going to need any additional support perioperatively. Whereas if you've done the oximetry and you get this kind of oximetry trace back, that will probably guide the decision about where this child has their operation done and how it's done in a different way. So we use oximetry predominantly to stratify severity rather than to make a diagnosis. And what that means is that you get a very lean model where the diagnosis is made clinically in the ENT clinic, and the only sleep study that is then needed is the oximetry to guide severity stratification. Now that does work in our hospital because we have access to a full range of options, but there is a way of thinking about this, I think, that means this can be helpful in other situations, other hospitals, to again help encourage that stratification. So again, you know, if you had a 3-year-old in a DGH that was confident in doing adenotonsillectomy for straightforward obstructive sleep apnea, but had an oximetry that looked like this, that might, I would imagine, influence whether you then loop in a tertiary centre for thinking about that. So that's how we think about it. Just to kind of emphasize the impact that you guys have. So this is a slightly different sleep study montage, but it's the same information. So you can see the kind of the regular desaturations and the apneas and hypopneas occurring. This is that child after they've had their adenoids and tonsils out. So again, if you're thinking in your head about that concept of sleep fragmentation, this child before his operation would have been having very fragmented, poor quality sleep. And after the operation, you've given him a much better quality sleep. And it's that improvement in the quality of the sleep that is going to make the difference in terms of the child's health and well-being. What do we do if it doesn't get better? We usually phone a friend. And this point, so if you've done everything you can do, then that is where we often are thinking about the more respiratory options, so non-invasive ventilation, tracheostomy. Just to finish off, I've been having this conversation about oximetry with my colleagues in the ENT department here for a few years. When I started, our oximetry numbers were on a definite upward curve. Since we started talking about this a lot more, oximetry is now the only sleep study which we are doing less and less of each year. And I think it's because we're increasingly getting that message across that oximetry doesn't help to diagnose obstructive sleep apnea. It's helpful as part of the assessment for some kids, but it doesn't diagnose, and the numbers are going down. And that is the only study type that we do where the numbers are going down. And because people like me are increasingly telling people that sleep is important, particularly in children, every other study type is going up. The coronavirus lockdown has accelerated this. We were already doing about 1/3 of our cardiorespiratory studies at home before coronavirus. We're now doing about 95% of our sleep studies at home, and the equipment to do this is better. So actually, even more detailed cardiorespiratory studies can now be done without children having to come into a sleep lab, and they give you absolutely great data. Right, last bit, just a summary then. So oximetry, specific use, mainly about severity. Cardiorespiratory study is pretty much all you guys need to be able to give you the extra information if you need a sleep study. Polysomnography, very rarely needed, and really it's just for those ones where you've got some specific queries or concerns that the clinical picture doesn't match the data you've already got. There is a great consensus statement that's now 5 years old, terrifyingly, that was published through the European Task Force that brings together consensus guidance about obstructive sleep disorder breathing in children, which I think is a much better statement than the Australian guidance. It's a much more judicious use of assessment, management, and resources. I have overrun, I'm terribly sorry. I'll stop there. I'm more than happy to take questions, and hopefully that was helpful in terms of trying to put in context what we are doing when we are trying to help you do what you are doing and make sense of some of the numbers and terminology. Thank you.
Thank you very much, Mike. That was fascinating and really, really useful. Lots of comments saying fascinating and thank you very much. I just wanted, the one thing I thought, just to add to that comment you made about that oximetry doesn't have such a big place and we use it more when we're already convinced, almost to help us decide whether we might need HDU or a higher level bed if it's terrible. I think the other thing is, slightly sadly, just because of the number of children we're trying to treat and the waiting lists, it also helps us a little bit decide on the urgency of treatment and whether we need to kind of expedite certain children. Absolutely. Because we're confirmed, gosh, they really are as bad as they look in clinic. So I think that's another area where it's help.
And I think it is. And again, you know, so if you've got a child on your waiting list and you know that their oximetry is a relatively flat looking line, then yeah, that gives you the confidence to say, yeah, we need to do this, but actually, so yeah, so that severity stratification on multiple levels is where I think it's important and useful. Actually, it's still a really important part. So it didn't come across on that slide because I put the oximetry separately. We still do lots more oximetry than anything else. And I think it is still useful, but it's just people need to understand what question it's answering, I think. As with any test. Do you want me to answer? Oh, sorry.
No, do you want to look at the chat and have a look? Or
Yeah, if you're, I'm happy to do that, and then that maybe makes it quicker. So I'll just go through them in order then. Numbers for oximetry are going down. Are we also finding the conversion rate for those who undergo oximetry is going up? I presume by that you mean, are we doing more cardiorespiratory sleep studies instead of oximetry? To which the answer is no. And again, I am phenomenally lucky to work with a really brilliant ENT team at Evelina London who really understand how to use us to get the most out of their assessment. So we don't find that we are doing significantly increased numbers of cardiorespiratory study. I think, as I said already, I think we are very lucky where we are, that we're a resource. We've got a brilliant team on both sides that are doing that. But the message is that that model, I think, is replicable in other centres. But what other centres, I think, may need is the confidence to know that the model works, which I think we can give. We've talked for a long time about writing up, and I just haven't got around to it. Would we say carbon dioxide monitoring is more important than oximetry? In all honesty, particularly with home studies, I'm usually quite happy for your patients not to need carbon dioxide monitoring. I think it rarely adds, you know, so if you had a sleep study that had normal oxygen saturation and a normal apnea-hypopnea index, but the CO2 was a little bit up, I don't think that would tip the balance for most kids to be the one deciding factor that would make you decide to do an operation. So I think usually where there is going to be something where the carbon dioxide is going to be useful, it's already obvious, in which case we'll do it. But actually the straightforward, typically developing children with adenoids and tonsils as the likely culprit, we don't usually find that CO2 adds anything additional, and it's then one less wire that has to be connected and has to be worried about. So we don't stress too much about doing the CO2 monitoring. Do I recommend every child undergoing surgery should have oximetry for risk stratification if not being operated on in an ivory tower? I think that is probably more a clinical question to ENT colleagues rather than to me. I think what that probably reflects more is the clinician's confidence in how much experience they have in being able to look at that. I think if using oximetry helps people to feel more confident that the right decisions are being made, I think that's appropriate. But equally, I'm fairly sure that there are many consultant ENT surgeons in many centres who would not feel that they needed to do that. Is that fair?
Yeah, I don't think it's necessary in everyone. I think if you have a child who is otherwise fit and well, who's 3 or 4 years old, who has a good history, examination findings are suggestive, but there's not significant red flag symptoms. And like you say, I think videos of the breathing at night are so useful. So if you've seen that and it looks relatively, you know, reassuring, and you have the rest of that story, I think it's very reasonable to proceed on clinical grounds. You know, as you say, in a centre who are used to doing young children with tonsils and adenoids, then I really don't think it's necessary.
But it is, you know, it's a relatively straightforward test to do and one that most centres have some kind of access to. So I think that's an individual centre. Any tips for grading sleep disorder breathing severity clinically, for example, in a DGH that doesn't have access even to overnight oximetry? I think exactly as Vicky just said, I think a lot of that then comes down to clinical acumen. I think the iPhone is probably the most useful addition to that in terms of being able to really see what the family are talking about. I think, you know, so overnight oximetry, pardon me, is relatively readily available. And so I'll come back to, if you don't have overnight oximetry, I think it probably is just that clinical acumen. If you do have overnight oximetry and nothing else, there are also published scoring mechanisms for using just oximetry. We are just starting with oximetry. So my ENT colleagues will have seen over the last few months that we've started adding a new measure into this called the Delta 12 index. And what the Delta 12 index is a way of trying to translate into numbers that eyeball that I was talking about, where I'm looking at the trace and saying, yeah, the numbers are normal, but to me, this looks like a, increased saturation variability and all the rest of it. What the delta 12 is doing is just measuring that saturation variability. And there's some evidence that the delta 12 is actually a much more sensitive marker from oximetry data than any of the figures we've traditionally used. And we're just feeling our way around that at the moment. So there are ways potentially to increase the utility of oximetry to analyze the data better, to give you better information if that's all you've got. But at the moment, we're kind of just playing around with that. The other thing that's going to come, so our adult lab are now doing a lot of this. There are new ways of doing sleep studies. So our adult lab are now doing a lot of something called WatchPAT, which stands for peripheral arterial tonometry, and that's measuring another proxy. So everyone's got very used to thinking about oxygen saturation as the ultimate marker of sleep disorder breathing. And hopefully I've persuaded you that it's that sleep fragmentation that's really important, and the oxygen saturation is just a proxy. So if it's just a proxy, if we can find another proxy that also tells us something about sleep fragmentation, then that gives us another way in. So one of the reasons that the cardiovascular health is impacted in sleep disorder breathing is that the tone in the peripheral arterial tone is very sensitive to sleep disorder breathing events. And we can now directly assess the peripheral arterial tone as a proxy measure of sleep apnea. And actually the data from adults is brilliant for that, and it gives discriminatory data that lets us produce obstructive and central AHIs from a wrist-worn device, and that's it. Which is a step forward. Yes, exactly that face. It's validated for children over the age of 12, and we will partly, again, this is a coronavirus-driven thing. We were talking about this before coronavirus anyway, but we will start doing this fairly soon for our sleep lab. Because it's only validated for children above 12, and actually because the vast majority of kids that you're seeing for sleep disorder breathing, particularly the typically developing adenotonsillar, are below 12, actually it's probably going to have a relatively limited utility for us to begin with, but we'll get there with that. I'm just aware of time and there's quite a few questions. Is there a minimum age to recommend adenotonsillectomy? Again, much more a question for my ENT colleagues. I think, so from my point of view as a sleep physician, an example I often give is I once went to a presentation at another London centre who were presenting a child, I think of about 21 months with Down syndrome, but big adenoids and tonsils, significant obstructive sleep apnea, and they had made the assessment and said, yeah, no, we can't operate on this child. And they were trying to get this less than a 2-year-old child with Down syndrome onto CPAP and completely failing. And they presented the case as a, oh my God, what do we do now? And those of us who were there from the Evelina went, well, I think our surgeons actually would be happy to operate on this child, and that's what we would do. So I think that is a consultant ENT decision, and I think that my understanding of that is it very much reflects level of expertise and experience, and I think we clearly do lots more of these children than other centres, so it's not criticism of other centres, it's just that that happens to be one of our strengths, I think. Is that fair? PSG, what would be my first line of treatment? Minimation recommends. So yeah, I think an AHI of 8 and a child of 1, yes, I would be saying if there's a surgical option, then yes, I think surgery would be the first line, because trying to persuade a child of 1 that they want to wear CPAP is fun, not impossible at all. But I think if there is a curative operation and a surgical team that are happy to do that surgical operation, then I would do that in terms of that. Do we use McGill grading? No, that's the thing I was talking about. We don't, I've been asked that before. I think it's purely actually that I think the McGill grading is trying to give a definitive answer from limited data. And I think what we have evolved within our centre is a very good understanding between the sleep side of things and the ENT clinicians about a more, what's the word, qualitative interpretation of the data rather than a quantitative one. And I think the McGill grading is really helpful if you want a quantitative answer to put something into that everybody kind of goes with. But actually what we do is we tend to use a much more qualitative way of doing that because it works better for our patients, I think, and that works for us. But in other centres, the McGill grading is an absolutely useful thing to do because it particularly allows comparison, and so everyone's talking the same language. Yep. In clinical suspicious child with STB, do we recommend more than one night oximeter? We do 2 nights as a matter of routine. We are sometimes challenged as to why we do that, and can we not, particularly by our managers, can we not just do 1 night and then it cuts the cost in half. We tend to find, again, particularly with younger children, doing 2 nights just means that you're likely to get good data. So if you then, the probe just falls off the first night and nobody notices. So doing 2 nights means that we get enough data most of the time. There is actually some variation. So again, you will be familiar with this, I'm sure, that you can do oximetry on consecutive nights. It's one of the limitations of oximetry is that you can do oximetry on consecutive nights and you can get different answers. So it lets us see that as well, and it means that you don't then end up in a situation where, I think we get there less now, again, because of the iPhone, but historically, you would have a child that had a rip-roaring history, you do a completely plumb normal oximetry, and the parents would still be saying, oh my God, really, that was just an atypically bad night. So we still do 2 nights. I think at some point we may drop it to 1, but we still do 2, but many other centers just do 1. And then the last question there, is there a meaningful place for pulse oximetry studies in diagnosis and treatment decision-making for sleep disorder breathing? So yes, within the caveats of everything I've already said, I think it's the most important thing is it's not a sensitive tool for diagnosis. It may help, as I say, in those settings where people just want that extra level of corroboration. But the most important thing for me is if you remember the AHI of the child, with the very flat-looking, completely normal number oximetry, and the AHI was in the severe range for childhood. So as long as you're not being falsely reassured by an oximetry in the context of diagnosis, then you understand its place. But I think it's a much more useful tool in the once you've got beyond diagnosis, as Vicky said, in either stratifying your waiting list or stratifying the perioperative management. I think it's much more useful there rather than in diagnosis. Done, I think, in terms of questions. Excellent.
Thank you so much, Mike.
Oh, thank you for having me, as always.
It was an absolute pleasure. Thank you so much for your time this evening, and thank you to everyone for joining and making it a really meaningful and with lots of questions session. Thanks, everyone.